Thank you so much. And thanks, everyone. And thanks a lot, Nirit and Minu, for the invite, because it's really great for me to be here and have an opportunity to talk, but also to listen and to learn a lot more about remote care and the work that the center is doing here, of course. And I look forward to being with you for the whole day and for the practical part in the afternoon. So my talk is titled Addressing Digital Inequalities, Designing with Care. And the question that I want to bring to the fore is a little bit like thinking about the challenges and the barriers that might be for people accessing remote care, depending on many of conditions, including, of course, social and economical conditions. I'm going to skip, I think I had this slide about myself and introducing myself, but I'm going to skip that one. So I can use the next 20, 25 minutes also to talk about these three main things. The first one is this idea of space and the importance of space in care. I'm then going to talk about the impact of digital inequalities and what these are, what they mean and how they impact access to remote care and the quality of care that we receive. And then I'm going to end with few considerations more than conclusion, really regarding the role of design in designing high quality remote care. So just to start and to position a little bit myself, most of the work I've done was in mental health and in the UK, where I've been working from 2014 to 2017 in the mental health setting, London and Southern England. And a lot of my work was using anthropology or ethnographic methods to learn about the needs of those experiencing mental health issues, their families and carers, and really thinking about how to use those insights and learning to improve services, to innovate services, to do recovery in different ways. And if you think about my work and my time in the UK researching mental health, you shouldn't think of me in a space like this. You shouldn't think of me in a waiting room or in a classic psychiatric wards with corridors and doors. But a lot of what I was doing was actually happening in spaces like this. Because a lot of the work that I was doing in the UK was, in fact, community mental health services. This is a different form of remote care that happens outside of the hospital and in the community. And the very central part of community, the very central idea of community mental health services is that they are designed and they are delivered within the community, closer to the community. Most of the time designed and delivered in collaboration with the people who live there, the people who might be experiencing mental health issues, but also, as I said, family and carers. And the point of delivering mental health care in the community is to make it visible. Because there is a kind of a very important byproduct of community mental health services that they kind of make mental health issues and services very visible in order to fight stigma around mental health. So spaces have been very central in a lot of the work I've done. And spaces have been very central, I would say, to healthcare and care design for a long time. We have been thinking about ways of planning and designing space that could influence better care relationship. We have learned the importance of looking after materials, their qualities, the navigability of the space, safety, of course, for patients, for staff, and for anyone external, but also designing spaces that could allow, for instance, for participation. So places where people could talk to other patients, patients to talk to other patients, but also where family and staff might get together and contribute in the day-to-day care. What has been happening as a result of digitalization is what scholars have defined a shift from a very placed central care to a post-place care. Now, post-place care, interestingly, doesn't mean that digital care doesn't have materials. Digital care also requires a network of actors to be involved in order to reconfigure care in different settings. And in fact, what we learn from this kind of literature and from these scholars is that post-place care is not placeless, but it's care that happens that is replaced somewhere else. And usually, but we have seen there's many, of course, options, but mostly it's actually replaced in people's homes. And these places, so our homes, become different type of places as a result, becoming more medicalized, perhaps. Now, interestingly for me was like reflecting on the word itself, and this idea of remote care, and thinking about the concept of remote from where? And you immediately realize that, of course, as a concept, is very much coming from a hospital-centered idea of care. If you look at it from the hospital, remote care is care that happens outside of the hospital. But that care is really not remote for those who receive care, perhaps in their homes. And these are all examples from dialysis care in the US, where actually care is happening in very personal and very cultural spaces, which are our homes. So the question for me that come to the fore when we talk about remote care and the role for design is how can we design from this kind of analog, very place-based care that we're used to a digital and post-place care. And what happens when we do this kind of shift in terms of redistribution of care responsibilities? I think we've heard a lot already from Nirit. How this shift to digital care transform the care places, and also how we reconfigure access to healthcare. And I'm going to focus mostly on the last part. So how digitalization and the digitalization of healthcare services is actually changing the way in which different people can or cannot access care. And this is where I bring the concept of digital inequalities, which is something I've been working and doing research on when I was at the Weissenbaum Center in Berlin. The concept of digital inequalities describes different things. The first one is how really paying attention to how existing inequalities in society do transfer in the digital world. But it also looks into how we observe the emerging of completely new forms of inequalities as a result of digitalization. And when it comes, of course, to think about digital inequalities in healthcare and through remote care, we think about challenges and barriers that are impeding certain groups more than others to access the benefit of remote care. So the whole concept of digital inequalities is quite a complex one. And scholars tend to exemplify or talk about it according to three waves, which are temporal, which happened at different time. And I'm going to go through the three of them very briefly. So the so-called first wave of digital inequalities is the one that perhaps we're all thinking about, the immediate one that the people think about, which is the digital divide, which was very much expressed through discourses of have or have not, which meant having or not having a computer, having or not having internet connection or good internet connection. And it developed around the 90s or beginning of 2000, of course. What is interesting of digital divide is that they still exist within countries, but they also very much exist in countries. And certain groups are, of course, more affected than others. And this study is just an example from work that I did when I was in the UK. This is also a post-COVID, immediately post-COVID study that we did that was commissioned by the British Red Cross. And they asked us to do a research to understand the level of inclusion, digital inclusion or exclusion of asylum-seeking people in the UK, in England specifically. So this was a very specific group. And we had a chance to talk and interview a lot of them, a lot of people living all around England in refugee centers or asylum-seeking centers. And what we found out, and these are just two quotes from the report, is that this group of people has all sorts of issues of access to digital resources when it comes to access your general practitioner or access any other form of care online. That goes from not having a laptop or a functioning phone, not having resources to pay for good broadband and internet, or the issue, of course, of living in shared and temporary accommodations where privacy is not really a thing, and therefore accessing healthcare, digital healthcare in those conditions might be challenging. it wasn't the focus of the study, but of course working with asylum seekers made us also very aware that the whole concept of carer home assumes that people have a home, first of all, and maybe also assumes certain types of homes. So what was interesting for us was that we started realizing it was an extreme case, of course, but it's not the only one. You can think of homeless people, of course. You can also think of students that might work and leave abroad, move abroad to study, and they might experience for a period of their studies or for a longer period of their studies moments where they don't have good accommodation or they have shared accommodation. So I think this is really important to take into account when we think about designing inclusive remote care. Where is the home? The second wave, so-called digital inequalities, move beyond the white and black conversation and discourses of having and not having digital access. And they focus way more on the complexities of digital inclusion, thinking about shades of inequalities. So inequalities doesn't just come as a black and white, you're not just excluded or included, but there's different ways in which you could be included and different ways in which you could be excluded. In fact, you might struggle to achieve the outcomes that you wanted to achieve through the use of digital tools. So it's not just a question of whether or not you can get online, but it's a question of whether or not you can, and what you can achieve by using different digital technologies, and whether you are in control of the outcomes that you get. This issue is really central when it comes to the so-called knowledge gap, because those who have higher social skills, those who have higher digital skills, will be able to get faster the communication or the outcomes that they want from the digital resources, which means that, of course, the gap between different groups, those who are more or less digitally included, is likely to increase with time as a result of this knowledge gap. The third wave, it's interesting because it shifts the focus, and we move from looking at the access to technologies, digital tools or platforms, into other ways in which digitalization still can exacerbate inequalities. And this is where more recent studies have been focusing on a series of issues like the data gap, especially in healthcare, and for instance, the so-called gender health data gap. It also looks on issues of misrepresentations as profiling. Profiles are built about patients through a series of data points that are collected, and it looks in how this data is used, perhaps to misrepresent people that are then introduced into this digital system. And more generally looks into how digital systems are increasingly built in ways that are opaque and really not always understandable or contestable from the point of view of the patients, which is also, I believe, a really serious issue. What is really challenging is that these three waves, although they happened in time, and we have been focusing on one or the other more or less at different points in time from the 90s until 2024, until today, they do overlap. They do all exist at the same time. So we have issues of the first wave as well as issues of the third wave. It's not that one has superseded the other. So this is a big challenge in addressing, of course, issues of digital inequalities when it comes to remote care. But also, research is showing us that these digital inequalities are here to stay. They're not going to disappear because we will never be as fast in addressing digital inequalities as fast as the technology is in developing new resources, new solutions, new tools, new languages. So what's interesting to think, again, when we think about the population and we think about digital inclusion in healthcare, is that even for myself, who might consider myself a fairly digitally included subject person, I might struggle to access digital care when I get older, because the digital tools that I will have to access at that time will be very different. So I might be confident and I might have the skills today, but I might still be struggling in 20 years' time or longer when I will have to access remote care. So the important part for me to point out is that there's many factors, as I was hopefully showing, that impact social exclusion and impact digital exclusions. But the ones who have the groups who are most socially excluded and the groups who are experiencing financial hardship, and we had one example from my own work, are the ones that are more likely to be digitally excluded. And interestingly enough, social and technological exclusion or inclusion are actually influencing each other. The more I'm digitally excluded, the more I'm likely, as I was showing you at the beginning, the more I'm likely to struggle to access the digital resources, the information that I have, and so to be left behind. And the more I'm left behind, the less social or financial or literacy skills I have, the more I will struggle to be digitally included. So this is a little bit of a vicious or virtuous circle. But it's important to understand that they do influence each other. So I'm coming to an end with the last session. And what I said before, I'm not bringing conclusions, but I'm bringing 3 considerations for how I think design might play a role in improving the quality of remote care, and also one provocation perhaps at the end. So the first suggestion, the first consideration regarding design has to do with the role of design. And for me, it's really not about just designing the interface, designing the space, or designing the objects that we're going to use. But the role of design in research, in understanding the problem, not just shaping the solutions, but really framing the issues that we have to tackle in remote care, I think is sometimes overlooked. And for me, it would be really central in understanding that care comes with a lot of nuances. Designers, and not just designers, talk about cultures of care. It's very value-laden concept. It's different in different geographical and cultural groups. And we need to understand these nuances by doing perhaps more research through design with the people that are going to receive remote care. Even understanding that there is, in fact, people that might have different homes, people that might have no home, or at least for a temporary or a long-term period of time, and people that might want to receive care in the communities. And of course, and we have been touching a little bit on that already, a more holistic approach will also make understand that research has to be done that involves all actors actually. So patients, but also workforce, and of course family and carers, to understand their points of view as well in framing the problem, and then use design also as a way, of course, of suggesting solutions. The second consideration for design is that we should understand perhaps design is more than just designing the technologies. Because we see designers used a lot in that space of how to design, again, the interface or other elements of a specific technology that we introduce in healthcare. But we should understand that these technologies are not just ready and simple to introduce in a complex system like healthcare. And they do need a lot of care work, they do need a lot of maintenance that needs to be taken into consideration from the design phase. And I'm thinking about issues of integrations in the health system. The new technology has to be, it's not easy to introduce successfully and efficiently in a complex health systems. Workforce, administration, patients, everyone has to be trained, understand the value, see the value of that technology, and have a whole system in place so that the technology can be integrated. Otherwise, it becomes like just a tech gadget that might stay somewhere in a room. We were talking yesterday. Until now, I think it's still like a little bit like strange to imagine from a design researcher's point of view, but there's still not enough user engagement and participatory design in the design of these technologies. And this is also where designers could play a role, again, not just in designing a technology, but in designing the system of participation around, so that we can include patients, carers, staff, family, from the beginning in conceptualizing and understanding what is the need of this new technology that we're building for remote care. And the third point, the third consideration, and the last one regarding the role of design, is actually about the role of designers in perhaps facilitating or holding conversations regarding trade-offs, which I think is an important conversation to have when it comes to the shift from, I was saying before, analog, let's say, to digital health. Because a lot of the times this is something that happens also as a result of cost-saving exercises or needs, and it has to be balanced with the need to still design and deliver high-quality standard of care. And there's still questions also from the research, still open questions. Or what is the trade-off? What are we losing by delivering remote care? And what quality are we designing remote care that is too transactional? And are we losing, therefore, the face-to-face, the value of the face-to-face relationship that people have when they receive more traditional healthcare with people and in an analog version? And of course, the other point, which I think Nirit also touched a little bit on, is the question of the burden of care. Because by moving care outside of the hospital and in other places, inevitably, we are reconfiguring this care relationship. And who takes more care ends up, through self-management, for instance, ends up being the patients, their families and carers who live all around them. And these are things that we should consider, and I think as design researchers also play a role in having these conversations or facilitating these conversations so that we can have the best trade-offs that we want. And I'm going to conclude with the little provocation. We were discussing, of course, with Minu and Nirit a little bit about the talk, and going back to the question of the symposium, which is this designing trust, building trust, designing with remote technologies. And I was wondering, actually, trust in whom? And one thing is when it comes to the trust in the people, and I actually like that we use that word, and I think it's a really rich and important discussion that we need to have. I'm not sure about using the word trust when it comes to technologies. Because in an ideal world, what I would like to have is not just people trusting technologies, whatever it is, and not asking too many questions, but I would like people to have a bit, I called it confidence, I'm not sure it's the right word, but having a little bit of like a capacity to make an informed choice, to know what kind of care they're receiving, to know what kind of technologies they're using or they are asked to use, what happens to their data, what happens to the monitoring, ask the questions of privacy, if there's surveillance camera in the hospital. So I would love to maybe think, and this could be part of the panel conversation, is really trust when it comes to technology? Is really trust the word that we want to use? Or are we rather trying to build, or should aim to build more confidence? Thank you so much.